Okay, sir. So we are going live in three, two, one.
One.
Please start, sir. We are live.
Yeah, will you do some introduction or should I start?
Good evening, all. Today we are here for our clinical conversation for prostate cancer CME, and our speaker for today is Dr. Vivek Agarwala. He is a consultant senior medical oncologist at Narayana Hospital. Sir will today teach us about the role of darolutamide in ERA-NOT and how do we uh, change the treatment paradigm regarding the therapies and all. So we will take the question answers at the end of the session. So, sir, I will request you to start your session.
Yeah. Uh, a very good evening to all of you. I hope I am visible and the slides are also visible and I am
Yes,
well
sir.
audible. So
Yes.
at the outset, I would want to thank Bear for giving me this opportunity. And today's topic is one of the most seminal discussions in the era of advanced systemic therapy in metastatic prostate cancer. And upon a choice in metastatic hormone sensitive prostate cancer, how to choose our treatment. And obviously, in the era of triplets, which is the regimen that preferably we should go to. There are no head-to-head comparative studies, but then this is the reason why we need to delve into the data a bit more carefully and try to take out some reasonable conclusions which can help us. So this slides are being provided by Bear and the opinion are by Bear. And if you look at the approval status, so far as the DCGI approval and label is concerned, then darolutamide is approved for the treatment of non-metastatic CRPC patients as well as for metastatic hormone-sensitive prostate cancer patients in combination with docetaxel and in combination with ADT. And it is indicated for the treatment of patients with metastatic hormone-sensitive prostate cancers, also in combination with ADT. Now we all know that in the era of triplets, the standard of care for any metastatic hormone sensitive prostate cancer is ADT plus one of the ARPIs. And this is irrespective of the timing of the metastasis, whether they are synchronous or metachronous, irrespective of the risk of disease, volume of disease, burden of disease, as well as the co-administration of any ancillary treatments like chemotherapy, like docetaxel or radiation. So clearly, in the current era, we need to look at whether our patient is a candidate for docetaxel or not, and if these patients are fit patients, relatively younger patients, likely to tolerate chemotherapy, having higher risk of disease, higher volume of disease, higher burden of disease, and are candidates for docetaxel, then all of these patients ideally should go for triplet treatment with docetaxel with one of the ARPIs, that is either abiraterone or darolutamide, as per the PIS1 and or the ARASENS data. And there is clearly no role for an intensified treatment with docetaxel alone without the use of any ARPI. So ADT plus ARPI is something that is there for all metastatic hormone sensitive prostate cancer and for those patients who are candidates for intensifying the treatment, we add docetaxel to it. There is no actual role for giving docetaxel alone. It's clearly demonstrated by PIS1 and ARASENS. Now, if you look at PIS-1 and Aracens, definitely somebody might think that there is no comparator arm of ADT plus ARPI. But then these were always high risk patients, and that is the reason why docetaxel was actually the comparator arm and not ADT plus ARPIs, which are, we all know, better agents in lower risk, lower burden patients. So, uh, almost a decade ago, we had paradigm change in the treatment of metastatic hormone sensitive prostate cancer, whereby we had the role of docetaxel upfront in metastatic hormone sensitive prostate cancer. The charted Getug and the Stampede studies, they all showed good, impressive overall survival benefits with impressive hazards with docetaxel. And we can clearly see the data being there. And if you look at the EAU guidelines, the EAU guidelines clearly suggest that for all patients who are metastatic hormone sensitive prostate cancer, ADT or a continuation or continued castration is always there. And those patients where the life expectancy is adequate, who are, having a decent life expectancy. We are talking about patients who are cross 85 years of age with multiple comorbidities. In these kind of patients, probably ADT alone may be, one of the treatments in such rare situations. But uh, in all patients, along with the ADT, if they are having somewhat of a good life expectancy, all these patients would go for either addition of ARPIs always, whether they are low volume disease or whether they are high volume disease. And high volume disease, the criteria that is usually followed is either presence of the visceral mets or presence of 4 or more bony mets with at least one bony met or more outside of the vertebral column or pelvis. So this is the clear classical definition of high volume disease that is acceptable worldwide. And in all low volume disease, RT may be given if there is no previous local therapy, and all these patients of low volume disease are candidates for ARPIs as per the choice of the discretion of the treating physician, whether it is a abiraterone prednisolone or it is one of the AR inhibitors like apalutamide or enzalutamide or darolutamide also. Whereas if patients are having a high volume disease, or some of the very selected patients, even if they have low volume disease but certain high risk criteria which are currently missing from our current treatment paradigm, then these patients, if they are eligible for docetaxel, then they are actually those candidates where upfront triplet combination needs to be used with the addition of docetaxel to either abiraterone with ADT or darolutamide plus ADT. This is how the EAU guidelines are also evolved. Now, docetaxel, obviously with the onset of charted studies, the Getug study as well as the Stampede study, every patient we used to think that would should go for docetaxel upfront. In CRPC, we would anyways give docetaxel, so why not give docetaxel upfront to these patients? And clearly there was a huge survival benefit given. But if you notice that some of the studies, uh, the especially the Stampede study, if you clearly see, the had showed a very good benefit of docetaxel, whereas the other Getug and the Charted study did not show the benefit of docetaxel to that extent. And what was the reason? And when you look at all these studies in a meta-analysis, clearly you see that docetaxel doesn't really, benefits each and every patient. So there are a small group of patients only who have a high volume synchronous metastasis. That is metastatic disease, which is occurring synchronously or seen synchronously, at 4 or more sites in the bones with one at least outside the vertebral column of pelvis or with visceral metastasis. High volume synchronous mets has to be there. If there is a high volume metachronous metastasis happening or a low volume disease in these patients, we can clearly see that the benefit of docetaxel is not so good, because you can clearly see that the range, the confidence intervals are actually crossing 1 in all these three. But in high volume synchronous metastasis, we can clearly see that the confidence intervals are not crossing 1, and they are between 0.62 to 0.84 with an impressive hazard of 0.72. Now, apart from the volume of metastasis or the burden of the disease, we also know that there are other risk factors that actually does influence and the benefit from docetaxel, and these are some of those factors which are actually thought to be major high risk factors, but are still missing from our guidelines because of the properly conducted studies. One is the nodal mets. So we all know, visceral mets is there, being counted as a high risk factor for high volume disease. But there are, if sometimes a lot of patients are there who present with nodal disease, having retroperitoneal nodes, mediastinal nodes, even supraclavicular nodes, multiple pelvic nodes, and these patients are actually not there within the definition of the high risk. But then there are, clinical retrospective evidence that these patients who have nodal metastasis may actually behave worse than some of the low volume bony mets. And also the T stage. And a higher T stage patients who are having T4 disease with involvement of rectum, with involvement of bladder, these patients are also those patients who are actually having higher benefit with docetaxel, but are actually missing within the guidelines. So this is one of the studies that was conducted in Lancet, published in Lancet, and they looked at the benefit of docetaxel in metastatic hormone-sensitive prostate cancer patients, a systematic review, and individual patient meta-analysis from the randomized studies. And when they looked at the margin of benefit between the ADT plus docetaxel versus ADT alone, then in T stage 1 to 3, you can clearly see that the curves are not really separating. But irrespective of the volume of the disease, if the T stage was T4, then you can clearly see that there is a clear separation of the curves, and a very early separation of the curves. So clearly this is one of those meta-analysis showing that a T stage T4 disease does really help in distinguishing patients who would be benefiting from docetaxel. So just as I said, that when we are looking for patients where they are high volume and we want to treat with docetaxel, then there is always this debate going on. There is no head-to-head comparison between the piece one strategy of docetaxel plus abiraterone plus ADT versus the Aracin strategy of docetaxel plus darolutamide plus ADT, and what to choose. And this is something that we will try to reduce in the next few slides. So this is the Aracin's study, and it was the only prospective study which was designed to investigate the combination of these three drugs, that is darolutamide, ADT, and docetaxel in metastatic hormone-sensitive. Clearly, they included treatment-naive patients. 1,300 patients were randomized 1:1 to docetaxel plus ADT with placebo, or docetaxel with darolutamide plus ADT. And they were stratified whether these patients were M1A, M1B, or M1C, depending upon whether they had visceral metastasis, bony metastasis, or nodal metastasis, and whether the alkaline phosphatase levels were actually higher than the upper limit of normal or not. And the clear primary endpoint was overall survival. The primary analysis was a very cleanly conducted clinical trial. And the primary final analysis was conducted after 533 deaths. Secondary efficacy endpoints were again tested hierarchically. And the first cycle of docetaxel was actually administered within 6 weeks of starting the study drug at the discretion of the investigator. So they gave good time for these patients to respond to ADT with dolutamide, and then there was a good interval of around 6 weeks. So again, this is one take-home message is that whenever you get your patients with metastatic hormone-sensitive prostate cancer with high volume bone mets, do understand that some of these patients will be having, heavy amount of bone disease with some of the marrow metastases, depressed marrow, and they are at high risk of early toxicity to docetaxel with neutropenia and neutropenic sepsis. So give some time. It is always good to give some time of 3 to 4 weeks to allow them on ADT and dialtamide, and then start docetaxel rather than starting them right away on docetaxel when some of these patients who would having heavy disease burden would actually have higher complications of docetaxel. So this was the piece 1 study. And actually, if you look at the piece 1 study, it was an open label study with a 2x2 factorial design. It was only conducted in the European Union, and it actually had 4 arms. Arm A was the standard of care, which was ADT or ADT plus docetaxel. And arm C was actually this standard of care, ADT or ADT plus docetaxel with radiotherapy. Whereas there was a pooled abiraterone arm which included standard of care, that is docetaxel with ADT, with or without docetaxel with abiraterone, and arm D was actually again the patients where the same combination was added with radiotherapy, and they tried to do multiple analysis actually to see which arm had a better overall survival and whether radiotherapy was acting good or whether the docetaxel was acting better. And they included patients only with de novo M1 disease and did not include patients who had recurrent M1 disease, has received prior ADTs or prior localized treatments. The patients were stratified as per the lymph node metastasis of bone or visceral, type of castration, and as well as LHRH, as well as agonist versus antagonist, and whether docetaxel was given or not. And if you see the entire study, the study actually started in November 2013-2015 when ADT alone was actually the standard of care in hormone sensitive metastatic prostate cancer upfront. But when the Stampede and the Charted data came in 2015 onwards, the study was modified to include, amended to include the evolving standard of care of upfront docetaxel, and docetaxel was permitted as the standard of care. And then only later in after 2017, then docetaxel became mandatory as a part of the standard of care. So the standard of care was actually evolving from ADT to either ADT plus docetaxel or ADT to docetaxel plus ADT. And what you can understand is that in all of the 1,300 patients who were enrolled in ARASENS, docetaxel was actually given to only 710 patients, that is 61% patients. Whereas if you look at in piece 1, but as look at ARASENS, all 100 patients, all patients received docetaxel, but in piece 1, only 61% patients actually received docetaxel. So that is where piece 1 was not a study that was designed upfront to look at whether the question that addition of an ARPI over and above docetaxel, does this give you an improved overall survival on. So if you look at both these studies, in the ARASENS, we clearly see that docetaxel plus ARPI combination was a pre-planned, and patients who had recent cardiovascular events or had NYHA class 3 or 4 heart failure were excluded. But if you look at the piece 1 study, the study had a lot of stratification factors, and only 61% patients received ADT plus docetaxel as standard of care. And they excluded a lot of patients, like patients who did not have hypertension being controlled well, patients who had contraindications to prednisolone because of many reasons, patients who had adrenal or pituitary dysfunction, patients who had was requiring cardiac arrhythmia or atrial fibrillation requiring treatment, or patients who had a ejection fraction of less than 50. So even an NYHA class 2 patients were excluded. And in our real life, what we will see is many of the patients, elderly patients, will actually be having, uh, these cardiac comorbidities or contraindications to prednisolone, or not suitable for prednisolone, and these are those patients we would actually be excluded from the actual study also. Now, these are the endpoints, and we can clearly see the OS analysis. At the end of 4 years, there is a clear 13% improvement in the triplet arm with darolutamide, with the median not reached yet, with the median being 48.9 months with the docetaxel plus ADT arm. And there is clearly a 13% improvement in the overall survival at the end of 4 years, with the hazard of 0.68, which is quite significant, and reducing the risk of death or by almost 32.5%. Very significant. But if you see uh, in the curve, what you clearly can make out that both the arms have started to separate right after the three months. So there is quite an early separation of the OS curve also with the Harrison's. But if you look at the piece one, so what you see with the piece one is that in comparison to docetaxel plus ADT plus docetaxel plus abiraterone, uh, eh, at the end of you know um, uh, 4 years, what you can see is that the hazard is 0.75 as compared to the 0.68. So the hazard is inferior. At the median of 4.4 years, the median was not reached in the abiraterone arm also, but the docetaxel arm, it is 4.4 years as compared to the same 4.4 years, for 4 years around in the but you can clearly see that the curves are not separating even after 1 year. At 1.5 years or 1.33 years, around 16 months, 17 months, you see that the curves being separating. So there is a very late separation of the curve, which tells us that probably these are long-term effects, and these are other biological factors may also be responsible, and not just epiretrone flow. So there was a delayed separation of the curve. That is what we see. Also, if you look at patients in the darolutamide arm, stayed on treatment for more than 2 years, longer than the placebo arm, and had a similar discontinuation rate due to adverse events as that of the placebo in the Aracens. So, similar patients having discontinuations, and almost more than 2 years is the duration of treatment for darolutamide. 1 months versus 16%. But if you look at the duration of treatment in piece one, again, uh, it is being shown as 34.1 months. There is a clearly 7 months lesser duration of the median duration of treatment. And if you look at the discontinuation, then the treatment discontinuation was almost 17%, too high as compared to the standard of care in piece one. Also, if you look at the completion of docetaxel, all 6 cycles of docetaxel, both the arms had more than 85%, 86% patients who were able to complete all 6 cycles of docetaxel. So darolutamide clearly did not affect the ability to complete the full 6 cycles of docetaxel. The combination was very well tolerated, and there was, it was not different from placebo. But in the piece one, they are not reporting the proportion of patients who completed all 6 cycles of docetaxel. And in real life, we know that abiraterone has higher toxicities and may cause lesser number of patients to complete all 6 cycles. Now, if you see the adverse events, clearly the adverse events, all grade adverse events, as well as the grade 4, grade 5 adverse events, they are all similar in both the arms. Placebo arm as well as the darolutamide arm, there are exactly same all grade adverse events. Clearly, what we can understand is darolutamide hardly adds to any added toxicities in Aracens. But in the piece one study, clearly there are much higher grade 3 adverse events in the abiraterone arm, the grade 3 or more adverse events is 63% in abiraterone arm as compared to 52% in the placebo arm, which did not receive abiraterone. Almost a 10%, 11% difference. Then severe hypertension is also 10% higher. Hepatotoxicity is, almost 10 times higher, 6% versus 1%. And this is why we need to understand that the adverse events are higher with the abiraterone as compared to placebo. Also, if you look at adverse events of interest between both the arms in Aracels, looking at metabolic adverse events which are associated commonly with ADT or ARPI treatment, like fatigue, vasodilatation and flushing, which are signs of andropause, rashes, metabolic issues like diabetes, hyperglycemia, cardiac disorders, hypertension, major adverse cardiac events, hypertension, weight increase, depressed mood, gynecomastia, cerebral ischemia, seizures. You clearly don't see any major difference. All these events are similar in both the arms. Only slightly there are higher incidence of rash and a slightly higher incidence of hypertension that we see in the dialtamide arm, and one or two patients having more seizures. This is what you see with darolutamide, and these are class effects that are obviously going to see. But what we can clearly understand is darolutamide is absolutely safe, just like a placebo, hardly has any added toxicity. So that is what we will see that in 2024, the APCC 2024 panelists voted on questions regarding the use of systemic triplet therapy. And when they were asked whether in high burden metastatic hormone sensitive prostate cancer who are chemotherapy fit, whether they would be adding triplet with ARPI and ADT, going with docetaxel, and majority of almost 54% were yes, and 40% actually said yes, but only in selected patients, whereas 6% actually said no. So almost 94% voted in the recommending triplet as the better treatment for patients. Whereas in low burden disease, which are even chemotherapy fit, in synchronous disease, 50% were not in favor of adding docetaxel, whereas 47% were only in favor, but only in selected patients, whereas only 3% were clearly in favor of adding docetaxel. Whereas in asynchronous disease, 87% were not in favor of adding docetaxel, with only 2% in favor and 14% telling they selected. So clearly, what we discussed that in low volume disease, usually we don't add docetaxel unless the very selected patients who actually have higher T stage or a very high nodal burden or are very, very young and fit patients, or with higher Gleason score. These are and high PSA score. These are those patients in the low risk where probably we might extrapolate the data and add docetaxel. Whereas in high volume disease, most of the patients we would add unless there is contraindication of chemotherapy or unwillingness to add chemotherapy, or not really tolerating chemotherapy, where we would go for ADT with AR. So definitely, these are the safety consideration need to be considered. That is, the triplet becomes an infusional treatment. There is chemotherapy toxicity, administration time, and the cardiovascular safety, cognitive, bone health, ADT adverse events, whether they're exacerbated or not, pill burden, and those different ADT related effects, especially with abiraterone, like hypertension, like edema, hepatotoxicity, hypokalemia. All these are definite important things to be considered whenever we want to select our patients for a doublet or a triplet therapy. So the take-home messages clearly is that we have now two very good studies, PEACE-1 and Aracels, which clearly demonstrated that addition of docetaxel with the ARP and ADT is the current standard of care for patients who are having a heavy burden disease, and only ADT plus docetaxel is not enough for these patients, and addition of ARPI improves the survival. Whereas we know that ADT plus ARPI becomes the standard of care for all metastatic hormone-sensitive prostate cancer, irrespective of whether they are high volume or low volume, synchronous or asynchronous metastasis. Additional intensification with a triple treat combination regimen approach should be considered as new standard of care in appropriate patients. And to proactively manage the adverse events of new treatment options, to optimize treatment outcomes, quality of life, survival, we need multidisciplinary care as a key to success, and need to consider multiple, additional factors to choose proper agents, proper ARPIs in our patients, and all eligible patients should be offered the benefits of all proven effective treatments to enable living with preserved and improved quality. With this, I thank you all, and if there are any questions, I would be happy to answer. Thank you.
Sir, thank you for your wonderful speech. Sir, we will just pause for 1 minute if there is any questions from the audience or our panelists. Sir, I think there is no further questions for that. So, sir, once again, thank you for your wonderful presentation. Sir, we hope that in future we will again give you as a speaker. We will take the opportunity to take your calls and your speak regarding the darolutamide. And this is all, sir. We are ending our meeting for today. Thank you, sir. Good night.
Thank you.
Thank you, sir. Welcome. I take him. We can close the meeting. Thank you for your support.